Welcome back. We are going to move on to chapter 20 and we're going to start with the concept of blood pressure. So here we have our little mosquito blowing up because the guy has high blood pressure. So very good for Michigan since we've all probably had an experience or two with mosquitoes in our lives. All right, so let's just start with terminology. So first of all, flow is going to come into play. Flow is a volume per unit time measurement. So you're talking about the volume of blood flowing through a vessel or the kidneys or the entire body within a specific amount of time. It's related to something called perfusion, which is going to be flow per unit mass. So you're going to take into consideration how big the structure is. And I'll give you an example of why this difference sort of exists here. Let's compare the skeletal muscles and the ovaries. So skeletal muscles make up the majority of your mass. They are, fairly gigantic. And the ovaries are roughly the size of about 2 almonds stacked on top of each other. So pretty small. If we were to look at flow, the skeletal muscles would have a much higher flow than the ovaries. But if we look at perfusion, if we take into account the mass, the perfusion rate is actually remarkably similar. So that's why those two exist. And you may hear one or the other depending on what someone is talking about. So blood pressure, fancy definition, force per unit area exerted on a cell wall by the contained blood. So how much pressure is the blood applying to the walls of the vessels? It's measured in millimeters of mercury. So when we talk about 120 over 80, which should kind of ring a bell, and you should be thinking about that cardiac cycle and going, the aorta topped out at 120 and then it dropped down to about 80 and then it went back up to 120 and then 80 because obviously the pressure in the blood that it's exerting onto the walls of the vessel comes directly from the left ventricle. So this is very related. The pressure is going to come from the ventricle, and that's going to have to do with cardiac output. The resistance component of blood pressure has to do with how much resistance the blood encounters in the peripheral vessels. So once it moves into the vessels, what is opposing its flow? And there are a few things that are going to play into this. The first would be the viscosity of the blood. Viscosity is a measurement of thickness, remember. So the thicker the blood, the more resistance. The blood vessel diameter is one of the fastest, easiest things for us to adjust to maintain pressure. If we constrict the vessels, then we're going to increase the amount of resistance. If we dilate the vessels, we are going to decrease the amount of resistance. And then blood vessel length also plays into this. However, it is not one of the variable components. Your blood vessels are a certain length. However, the taller you are and the longer the blood is in the vessels, the more resistance you are going to encounter. So here we can actually see how pressure actually changes as we go through the different vessels that we'll talk about in another module. So you've got the aorta at your 120 over 80, and then as you continue out into the systolic or the arterial, you see that we're able to keep some pressure, but when we move over into the veins, we have almost no pressure at all. So pressure is variable in the blood. That's why we measure pressure in arteries and not veins, because we wouldn't get a very good reading of what's going on in the heart by looking at the veins. Okay, so now that we have kind of a technical definition of blood pressure, we're going to dive in and we're going to go a little bit deeper and really get to all of the different little individual pieces that make up blood pressure. So we're going to start here with the fact that blood pressure is going to involve cardiac output, which we've talked about before, so the volume of blood that's being ejected per minute, times peripheral resistance, which is how much resistance the blood is going to encounter out in the periphery. So let's start sort of adding in some of the stuff that we already know. So we know that cardiac output is the product of stroke volume times heart rate. So that is something that we've talked about before. We also know that stroke volume is going to be found by taking your end diastolic volume and subtracting your end systolic volume. So that's how we get stroke volume. We talked about a few different things that would come into this and play into this. So we talked about an ion, calcium, that is going to have a direct effect on stroke volume. So as calcium decreases, stroke volume would also decrease, so the availability of calcium is important. And then we also talked about two kind of concepts, if you will, things that are hard to really picture, but certainly are playing a role here, which would be preload and afterload. Now, the most direct way of thinking about these is that preload has a fairly significant effect on EDV. Because we know that preload has to do with the stretch of the ventricle, and we get that stretch by increasing the volume. So preload is going to have the most direct effect on EDV. Afterload is a little bit more difficult to pinpoint in a really truly a direct manner here. But if we want to kind of put it somewhere, it's going to, I would say it's probably, the best way we could put it is to say that it's going to directly affect stroke volume. That's probably our most direct way of looking at this. So as preload increases, EDV increases, which means stroke volume increases. As afterload increases, it's going to be more difficult to get that semilunar valve open, and less of the ventricular contraction is going to be used for ejecting blood. So as afterload goes up, stroke volume goes down. So if preload goes up, stroke volume goes up. If afterload goes up, stroke volume goes down. Now, cardiac output, we want to keep stable. So this is the most important sort of piece to keep fairly stable under normal physiological conditions. So anything that causes stroke volume to go down, stroke volume to drop, is going to cause heart rate to go up in response. There are numerous pathological processes that are related to that direct link. That anytime stroke volume goes down, heart rate goes up, and it doesn't always fix the problem. All right, we said that heart rate was going to be affected by mainly our autonomic nervous system. And then that we would find some other chemicals, ions and hormones and things like that, that would also affect it, that we will see coming in here in a minute. But we said the autonomic nervous system was the most direct relationship to heart rate. So you can see that this is already getting fairly big, and it's not going to stay nice and neat for very long. Now, we just talked about some different things that were going to affect PR. Now, I'm only going to put the things on here that are actually variable. So in other words, I'm not going to put down vessel length, because vessel length doesn't change. It's not going to affect blood pressure differently in one direction or the other. Your vessels should, in fact, stay the same length. But we do have a few things that we are going to put over here on the PR side, starting with the volume of blood. And when you think about the volume of blood, think about things that have to do with water. Okay, this is the most, again, I'm giving you the most direct effect. We could make this much messier if we wanted to, but I'm giving you the direct effect here. So blood volume, as it goes up, there's more blood in the vessels, there will be more resistance, and PR will go up, and that is most related to how much volume there is. Blood viscosity is also related to this. When you think of viscosity, the easiest thing to think of is anything that affects red blood cells increasing. Now, are volume and viscosity related? Definitely, absolutely, they are related. However, to simplify this in a way that's going to make more sense, when you see something that's affecting water, think about volume. When you see something that is affecting viscosity, think about red blood cells. Last one we're going to put over here is going to be vasoactivity, which comes in two varieties. We've got constriction and we've got dilation. So this has to do with the diameter of the blood vessels, and so if we're going to change the diameter, then that is definitely going to affect peripheral resistance. Okay, so we've put together all of the different components that play into blood pressure. Now we're going to talk about some of the controls of it, starting with a set of neural controls. These are very fast-acting reflexes. They are not designed to create long-term changes in blood pressure. Think just a few seconds type of thing. So here we've got a loop, homeostatic loop. We're using baroreceptors. So this is the baroreceptor reflex. So we've got baroreceptors, which you should remember are pressure receptors, in the aortic bodies and the carotid bodies. And so basically you're thinking of the big thoracic vessels and the neck, where you still have very high pressure in the blood. So if these pick up that pressure is too high, then they are going to send that information into the cardiovascular center in the medulla oblongata, and we're going to decrease the amount of stimulation on the heart, and we will vasodilate the vessels, which is going to, between the two of them, drop both cardiac output and peripheral resistance, bringing us back down to normal. If we don't have enough pressure, so our baroreceptors are not stimulated enough, again, we send this information into that cardiovascular center. We increase everything. So we're going to increase heart rate, contractility, cardiac output. We're going to vasoconstrict, and that's going to bring us back up by increasing both cardiac output and resistance. So you have these very fast-acting responses, and then as soon as you come back into normal, you're going to use your negative feedback to shut all of this off. So, if you jump out of bed really quickly and you feel your heart rate go up, it's because your blood pressure dropped, and then your cardiovascular center told your heart to increase the rate, but it doesn't stay up all day. As soon as we come back to normal range, it's going to shut this off via negative feedback. We also have a chemoreceptor response. This one is going to deal with the amount of CO2 and therefore the pH level in your blood. And so this works best in the respiratory system, so we're going to come back to this in the respiratory system. We also have what's called the medullary ischemic reflex, where the brain monitors how much blood it's getting, and if there is a drop in the amount of blood coming to the brain, the perfusion of the brain, then it will directly cause the increase in CO and a vasoconstriction to try to get pressure up high enough to get the blood up to the brain. So these are all neural controls, again, very, very fast acting and not designed to be long lasting. All right, so now we're going to talk about some hormonal controls. And what you're going to notice here on this table is that most of them increase your blood pressure. As far as your body is concerned, high blood pressure is not a true acute life-threatening problem. And therefore, we don't have a huge number of mechanisms to drop our blood pressure. Not having enough pressure, hypotension, is life-threatening. So we have multiple different ways of increasing our pressure to make sure that we are perfusing the body properly. So that's definitely something to think about as you go into all of these controls, is that hypertension will kill you in like 30 years after it's damaged your blood vessels and all kinds of other stuff. It will absolutely kill you. Hypotension will kill you right now. If you go into circulatory shock and we don't fix it, you die. And so your body is way more concerned with hypotension. So you're going to see mechanism after mechanism to raise your blood pressure and very few to drop it. So let's talk about these hormones. Starting with epinephrine and norepinephrine, the effect on blood pressure is to increase it, and it is going to do it on both sides of the equation. It increases your cardiac output and peripheral resistance. So this is a very powerful chemical. This is your sympathetic nervous response. So this is your fight or flight. And we've talked about the fact that fight or flight should not last forever. So again, this is not something that is designed to be long-term. Let's go down to these two, because you learned about these in 251. ADH, antidiuretic hormone coming from the posterior pituitary. It is going to cause you to increase your blood volume by causing your water to be reabsorbed in the kidney tubules. It does do a little bit of vasoconstriction, but that's certainly not its major one. Really, it is this one. It is going to cause you to reabsorb water, which is going to increase your blood volume. Aldosterone is going to do a similar thing, but it is going to cause you to reabsorb sodium, which causes you to reabsorb water, which increases your blood volume. Angiotensin II is the start of what's called the RAS system, which is partially hormonal and partially the renal controls. Angiotensin II directly causes vasoconstriction, but it also, we'll find out in a second, causes the release of ADH and aldosterone, which would increase your peripheral resistance via blood volume. So angiotensin II, ADH, and aldosterone are all kind of related. Atrial natriuretic peptide is one of the natriuretic peptides that we have. It is the only one that decreases your blood pressure, and it does so by causing vasodilation. So most of our hormones are going to be increasers. They are designed to make sure that we have enough blood pressure to perfuse particularly our brain and then the cardiac muscle, these things that are keeping us alive. All right, so let's go ahead and add in our hormones that we just talked about. So we'll start with epinephrine, super powerful because it affects both sides of this equation. So we'll throw epinephrine right in here. Epinephrine is a powerful vasoconstrictor, so it's going to increase PR, and it's going to increase both your heart rate and overall contractility of your heart, so you're going to get a big output in, or increase in cardiac output as well. So epinephrine is so powerful because it really does work on both sides and is going to dramatically increase your blood pressure. The next couple are going to work on blood volume. So they're going to do it in slightly different ways. So we've got ADH and we have aldosterone. Both of them are going to cause increases in blood volume. ADH is going to increase the volume directly, causing kidneys to reabsorb more water, and aldosterone causes the kidneys to reabsorb sodium, which is going to reabsorb water. Both of those are going to increase PR. Anytime PR goes up, blood pressure goes up, because you can't drop cardiac output to compensate for an increase in PR. You can't decrease the amount of blood, only so far. So we can't really compensate by dropping CO, so changes to PR, increases in PR will increase blood pressure. Now you know that both of those are going to be released in response to angiotensin 2. So that's where that one is going to come into play. But angiotensin 2 is also going to directly cause vasoconstriction as well. So as promised, this is going to get a little messy. So you've got angiotensin 2 that's driving the production of ADH and aldosterone that are driving blood volume up, that are driving PR up, but you also have the vasoconstriction that is directly related to PR. So angiotensin 2 is a powerful chemical. That's why we pay attention to it. It's got a lot of downstream effects. And then the fourth effect, which isn't really on here, is to increase your thirst, which would eventually increase your blood volume, which would increase your PR, which would increase blood pressure. Now, the only one that we don't have up here is atrial natriuretic peptide. And that one, atrial natriuretic peptide, is going to trigger vasodilation. So that is the only one that's going to drop your PR to try to decrease blood pressure. Like I said before, your body is more concerned with making sure that you have high enough blood pressure to perfuse particularly your brain and your heart. So we're not super concerned about decreasing it. We do have the natriuretic peptides that will do that for us though. So you can see very quickly that this becomes very complicated, and you really have to understand these interrelationships. I can assure you that on your exam, I will be asking you questions that you're going to need to be able to reference this. I'm going to ask you a bunch of questions that have answers that are simply increases or decreases. And it's just going to say, for example, the release of atrial natriuretic peptide on peripheral resistance decreases. Okay. Let's see. So the effect of a decrease in preload on heart rate increases. So you need to be able to walk yourself through all of these different pathways and understand how they're going to change when a variable changes. So spend some time here, really work on this and understanding this, because quite frankly, this is going to come up again. We're going to see it in the kidneys, we're going to see it in the balance chapter, we're going to see this over and over and over again. So do yourself a favor and work on it now when this is, kind of new, and don't put it off until later, because if you don't get this now, you will end up having to get it later. And this is going to be a pretty significant component of your first exam. So definitely focus on this. And the renal controls. So the renal tends to be maybe a little bit longer in terms of how long it takes, although it's still not long, compared to a neural or an immediate hormonal response. So we have what's called a direct renal mechanism, where as arterial pressure decreases, your kidneys stop filtering quite as much. You decrease your urine formation, which means you're going to hold more water in your body. You're going to increase your blood volume. Pressure is going to go up. So your kidneys, the major thing that they can do is going to be to hold water in the body and not urinate it out. So that's going to be their big player here in terms of blood pressure maintenance and why they are so important. The indirect renal mechanism is what's called the renin-angiotensin-aldosterone system, or RAS, R-A-A-S. So this is a pretty powerful system. You're going to have decreases in arterial pressure that are going to increase the sympathetic nervous activity, causing your kidneys to release the enzyme renin, or renin, either way. Angiotensinogen is a inactive form of angiotensin that is made by the liver and is going to be out in our blood all the time. Remember, ogen means inactive form of. So it's out there, but it's not active. It can only be converted to angiotensin 1 in the presence of renin. Angiotensin 1 then requires another enzyme, ACE, or angiotensin converting enzyme, that comes from the lungs to convert angiotensin 1 to angiotensin 2. This is our powerful chemical. This is where we're at. Okay, this is our hormone that's going to have a big effect. First of all, it's going to target the adrenal cortex, causing the secretion of aldosterone, which causes increases in sodium reabsorption, which drives water reabsorption, which increases blood volume, which increases pressure via peripheral resistance. So that's one pathway. Second, targets the posterior pituitary and causes an increase in ADH, which directly causes water reabsorption, increases in volume, increases in pressure. Targets the hypothalamus and causes you to increase your water intake, which increases volume, which increases pressure. Now, obviously, this one's going to take a little longer. Okay, it's going to take you got to get the water, swallow the water, absorb the water. Okay, and then the fourth is going to be that angiotensin 2 is in and of itself a powerful vasoconstrictor, and it will dramatically drive up peripheral resistance on its own. That is a huge amount of reactions that are going to occur in response to angiotensin 2. So when somebody is suffering from hypertension, one of the things that we do if diet and exercise changes have failed or the patient refuses to do the diet and exercise changes, so we have a whole class of drugs that we can do. Some of them are angiotensin receptor blockers. They basically allow you to make angiotensin 2, but they compete with the receptor. Others are what are called ACE inhibitors. They inhibit this enzyme right here, which eliminates angiotensin 2 from being made, which is going to decrease the ability for you to do any of these. So we have multiple different systems involved in maintaining blood pressure, because if you don't have blood pressure, then you don't have a long time to be here. We got to fix this, and your body is very concerned with maintaining a high enough blood pressure. So here, this is just a nice little sort of wrap-up table. I'm not going to ask you to recreate it or anything, but basically you should be able to follow each one of these lines and understand why this is occurring. Okay, this is very similar to what we kind of drew on the board, except we're adding in sort of the pathology that would lead to these different things. So this is not the place that you should start studying. It is the place that you should come to after you are done studying and see if you understand it. It's a good place to check your understanding. Now, the imbalances that I've been talking about. Hypertension is when systolic is above 140 or diastolic is above 90 over many readings. A lot of people have what's called white coat hypertension. They get nervous at the doctors, and so their blood pressure registers higher. So before we diagnose somebody with hypertension, we want to see that the readings are occurring multiple times. Now, hypertension comes in a primary and a secondary way. Primary, aside from a couple different risk factors, is kind of boiled down to almost a lifestyle choice. The two that you can't really change are your genetics and your age. There are people who are genetically predisposed to having hypertension, and we definitely see a loss of elasticity in our vessels as we age that is going to cause hypertension. But diet, obesity, type 2 diabetes, stress, and smoking, which are the major risk factors for this, those are all choices. These are all choices that people make. And they are all related to each other. We see diet, obesity, stress, smoking, type 2 diabetes, they're all related. And so many cases of primary hypertension can be fully reversed without ever taking any of the drugs simply by changing their lifestyle. These are lifestyle choices that are causing this hypertension to exist. If you change them most of the time in most of the population, it will reverse, just like you can reverse type 2 diabetes by changing your diet and increasing your exercise. Secondary is due to and something else, essentially. So, for example, if you have kidney disease and your kidneys aren't responding to all these hormones the way they should, then you can have hypertension. The hypertension is secondary to the kidney disease. If we treat the kidney disease, then the hypertension will go away, hopefully. And so obviously these people absolutely need drug therapy because over time hypertension will damage your body. But these people really should be advised to try diet and exercise before taking a drug like an ACE inhibitor that essentially eliminates your ability to raise your blood pressure. I mean, what happens if that person goes into shock? They're on an ACE inhibitor. They're not going to be able to respond the way that they should. So it's a powerful drug, and when we have the ability to reverse this simply by changing diet and exercise and lifestyle, we should really try that first. Hypotension is when you are less than 90/60 in an acute way. I got to throw this in because there are certainly people who have very low blood pressure. I am one of them. I can get readings of 90s/60s and it's not abnormal. But if normal is 120/80 and you acutely drop to less than 90/60, you're going into circulatory shock. And so this is one of those things where you really want to pay attention and know what's normal for you so that you know if there is something that's abnormal. So let's talk about shock. Basically, shock is when it's kind of an umbrella term and you have an inadequate amount of blood or the blood is not circulating properly through the system. So the first type of shock is what's called hypovolemic. You have a large-scale loss of blood or fluids, so massive hemorrhage or massive dehydration with loss of fluids. You don't have enough volume, okay? So your heart is pumping properly and your vessels are the right diameter, but you don't have enough fluid in them, and so your peripheral resistance is dropping significantly, and eventually your blood pressure is going to drop, and we need to get fluids into this person. Vascular occurs when the blood volume is normal, but you have widespread vasodilation that's going to dramatically decrease peripheral resistance. This occurs in anaphylactic shock and septic shock. Anaphylactic shock is a response of a type 1 hypersensitivity, so we'll talk about those in the immune system, but basically you are running into an allergen that causes all of your basophils to degranulate, and all of those inflammatory vasodilators are released, and you get a systemic vasodilation that drops your pressure. Septic shock is going to follow the same pattern, but instead of being an allergen, it is in response to a bacterial toxin. So obviously those two need to be treated differently. With one of them, we're really dealing with a bacterial infection and antibiotics are very appropriate. And the other one, we are dealing with an allergic response, a hypersensitivity, and we need to treat it in that way. Last type of shock is what's called cardiogenic, and this is basically heart failure. So now your vessels are fine, you've got enough blood, but your heart isn't pumping it properly. So when you're having an MI or you're going into right or left-sided heart failure, then you can go into shock because the pump is not working. Again, here's one of these little tables that is going to take a whole bunch of stuff and put everything together that we talked about. This is basically hypovolemic shock. So you can kind of walk yourself through it and see what do you think would happen and see how well you feel like you understand these. Again, I'm not going to ask you to recreate this under any circumstances, but it is these flow charts are good points of checking and saying, do I understand